welcome to the stage. Please welcome to the stage Dr. Chelsea Clinton, Mayor Sean Patterson Howard, City of Mount Vernon, Reshma Sujani, and Shahed Alum.
All right, everyone, thank you so much for joining what in many ways is a continuation of the conversation that my mother and Secretary Yellen were just having on this stage about kind of all that we need to be doing to kind of better support women, particularly women who are mothers and who want to, are compelled to, have to, choose to work. So really excited and grateful for our panelists and mindful of everyone's time and that we're running a little bit behind time. So forgive now the abrupt and inelegant segue right into the conversation. So Madam Mayor, I wonder if we can start with you. I do want to talk about maternal health, and one of the kind of core areas of focus for us here at CGI and for this panel, but kind of to ask kind of you in your public service career, did you just always know, maybe because you are a woman, that kind of enacting policies, having kind of regulations in place to better support working women was going to be part of your charge? Or was this something you kind of realized in a campaign or once you were in office, like, oh, I really do have to focus on that because everyone before me hasn't necessarily done it?
So I came to this office after 30 years in social work and human services, and after 15 years of being a CEO with the YMCA, which is the largest child care organization, and then a history of public health work. So I understood as a woman and as a professional over my career that this is absolutely the charge of those of us who are also in elected office when we have the opportunity to make policy, to ensure that child care and paid time off is available, that child care is affordable, that we are dealing with the social determinants of health. Because the social determinants of health, from housing to economic stability to the built environment to the safety of neighborhood to access to quality and affordable but quality health care, as well as our mental and emotional wellness, are all very critical. We oftentimes just talk about prenatal care, but preconception health is critical, because if we are not healthy before we become pregnant, then it is going to be very difficult for us to catch up during pregnancy. So from preconception to prenatal health to health throughout the pregnancy, and then the critical fourth trimester that we're talking about, not just 3 months, but really for a year post-delivery. We have to focus on the health of the mother and the child, ensuring that there's access to breastfeeding education, ensuring that there's access to transportation and mother and child health care, ensuring that mental health services are available because mothers are dealing with a lot of mental and emotional health. We oftentimes tell people to get well soon. Well, that's the problem. Everything is a rush. Get back to work, get back in shape. 6 weeks are over, get back to your duties. And we're not really focused on the long-term health of the mother and child. And the bigger challenge is, as a Black woman who's been pregnant twice, who lost a child, a daughter, early, and who almost lost my life on the birthing table, and then my first daughter was born premature, not having medical health providers, when you do have access to quality care, when you do have a good job, when you live in a safe neighborhood, when you do have great education, not necessarily having a culturally competent or culturally sensitive healthcare system in this country, where we see Black women dying at 3 times the rate and Black children dying at 2 times the rate during childbirth and right after childbirth and even in utero. It's a major challenge. And so not only am I the mayor of the city of Mount Vernon, but I am nationally the president of the African American Mayors Association, representing over 500 Black mayors across the country. And the one thing that we see see is the disparities in healthcare amongst Black women. And so to ensure that our mayors throughout the country and other mayors have access and a good roadmap, the African American Mayors Association, in partnership with our Business Council and after consultation with the Department of Health and Human Services, has created a Black maternal health toolkit to ensure that there is a very clear, succinct, directed roadmap that helps mayors understand the policies that they can put in place, like paid time off, to ensure that they're creating networks within their community, to ensure that WIC and mental and emotional health services.
Explain what WIC is, maybe, for people
WIC,
who don't know.
Women, Infants, and Children, making sure that there is access to nutrition, because nutrition is important. And in the time period that we're living in with inflation and other challenges, we have to make sure that women and their children and families have access to the very basics. It makes a difference. And anyone who tells you that it doesn't is really foolish. We have to,
or already has access to those services.
or already has access. I think it's really important that we find, I worked in HIV/AIDS for 15 years. Well, 20. And one of the things that we talked about was universal health precautions, to treat everyone the same way, so that we wouldn't have to put people through a lot of different questions. Well, I think it's really important when we're talking about women's health and maternal health that we create screening tools. We do domestic violence screening tools for women who are pregnant, but we don't do screening tools that deal with those social determinants of health, understanding their housing, their access to nutrition, transportation, quality medical care. If we create a universal tool and create policies that are universal again, then we won't put women in a position where they have to ask for help or tell their poverty story or talk about their deficits over and over again in seeking help. But if we find a way to create universal policies and universal tools, and that's a part of the screening tool, whether you're in NYU or you're being seen at a federally qualified health center, then we can find out the needs of the woman and her children and her family up front, and we can begin to put together care teams and ensure that she has access to service and that she's supported. And then I guess the last thing that I want to say on this is, as part of that fourth trimester also, as I speak to doulas and other women in maternal health, it's important again that we deal with our physical health, not just losing weight, but making sure that we're preserving and we're protecting and we are strengthening our pelvic floor, because that impacts future childbirthing experiences, as well as just basic continence on a day-to-day basis. We're in a rush to get back to work and get back into our pre-maternity clothes and everything else that we're responsible for, but we're not taking care of all aspects of our mental and our physical wellness.
Well, Madam Mayor, I'm now going to pause before I tell someone to get well soon, unless maybe they're recovering from a broken bone and they have a very clear trajectory forward, hopefully. But you certainly have already given me quite a bit to think about. I think, too, highlighted in your answer is how like bluntly, painfully understandable our maternal mortality crisis is in this country. Because here in the United States, we have the worst maternal mortality crisis in the global north, in the industrialized world, in the wealthy world, kind of however you want to kind of situate us. And as the mayor said, our maternal mortality for Black, brown, and indigenous women is even worse. And actually here in New York City, it's 9 times. A black woman is 9 times as likely to die in childbirth as a white woman is, controlling for neighborhood, income, education, and kind of every other potentially correlated variable. And while it is the social determinants of health, it is also our opioid epidemic crisis, it is our gun violence crisis because of how many pregnant and postpartum women are murdered with a gun, kind of by their kind of intimate partner. And so this is such a clearly, painfully American challenge. And yet we do have leaders, thankfully, in government and outside of government who are also using kind of the very American qualities of kind of ingenuity and determination to name these challenges and to tackle them head on. And Reshma, you're certainly kind of someone who is never, thankfully, afraid to be
living, are not able to actually live a livable wage because of the cost of living and the cost of childcare. But yet we do nothing about it. And when we think about the fourth trimester, you cannot not think about that stress that you have of not just your body and have I physically recovered, but like, how am I going to find food to put on the table? How am I going to take care of these babies that I just gave birth to? And what the world would look like, if we did actually have the respect for women and children. And when I talk about this, people always look at me sometimes like I'm crazy. And like, I'm not crazy, I'm talking about Norway. You know what I mean? I'm talking about Canada. The type of nation and society that we want to build is something within reach. And I do think that the work that we're doing at Moms First is to engage in the private sector, as the Secretary talked about this morning, getting more of them to subsidize childcare, both for salaried workers and hourly workers. But we can't do it without a federal solution. We can't do it without doing something that Canada just did 2 weeks ago, which is just create a floor of how much every family is going to spend on childcare. I don't know if folks saw, but the New York Times just had a story out 2 weeks ago, right? About it doesn't matter whether you are a banker or working in retail. Every single family, regardless of race, socioeconomic status, is struggling to make ends meet because of the cost of childcare.
I wonder kind of if you can share kind of insights from your work with HealthWorks, which I know works in, I believe, Indonesia and Bangladesh, and kind of your work particularly with helping to support new mothers and newborns, because I do think Reshma, absolutely we need to kind of feel the kind of moral clarity, and I don't think it's just to see it. I think it really is about kind of feeling it when kind of countries with resources prioritize investing in women and children and families broadly. I think also we have a lot to learn from everywhere in the world where work is being done to improve health outcomes, physical and mental kind of well-being for new moms and babies. So I hope you can share a little bit about your work.
Yes, very, very grateful too. And actually, it's really meaningful for me to be here and sharing this because my co-founder in this work is actually in her fourth trimester herself. So there's about 2.5 million newborns that die every year globally, and most of these deaths happen within the first week of birth. There's almost 300,000 mothers who die, an unacceptable amount. And many of these deaths can actually be prevented just by health practices, common health practices that we know are evidence-based and we know and can be performed at home. And it's, of course, not just about saving lives and saving mothers and newborns' lives, but the fourth trimester is an incredibly critical time for physical health, mental health, for the social aspects of care as well. And these are the things that we try to focus on when we engage with families. So our model is not just to focus on working with mothers, but the whole care ecosystem around the mother, which includes, in the places that we work, which also includes India, the grandmother especially, and of course the father, and the other key players in the community who will support the care of both the mother and the newborn. And we teach them basic things like skin-to-skin thermal care, so that there's warming of the baby, there's the bonding between the mother and the child. We also get the father involved in skin-to-skin thermal care. It's one of the most effective interventions, especially for low birth weight babies, which is a very common thing in the places that we work, but can take hours most of the day actually, to actually provide that care. And so bringing the fathers into it, bringing other family members to actually practice that is just one small way that we kind of have that ecosystem supporting care. Of course, things like exclusive breastfeeding, early initiation of breastfeeding, reducing things like infections through common and basic practices like hand washing and cord care. And so all of these things we try to bring through the public health system, and not only have that information be shared by healthcare workers, but have this be supported through mobile phone outreach. So in a lot of the communities that we work in, there may not be a water tap that is there in someone's home, but they do have a phone. And sometimes now we see commonly a smartphone. And so the engagement and the training the family receives in the healthcare facility is just the beginning, and then we follow up through people's phones and provide them simple reminders, messages, and answer their questions. And each of these questions that we answer can actually save someone a trip tens and maybe sometimes even hundreds of kilometers to go and follow up with a hospital or a healthcare worker. So kind of all of these things put together, getting the right critical basic information to the family, not just the mother, the whole care ecosystem around the newborn and the mother, and at the right time, we've seen can actually save lives. So we've done some research on looking at what happens if you share this information at the right time. And we see that newborn deaths come down by 18%. And in the places that we work, this means that 9 babies' lives are saved for every 1,000 live births, which is an incredible amount. And just because of these basic things that we all know would support the mother and the newborn better. And at the same time, we also see maternal complications coming down. So this is just the beginning, of course. We do see that not all behaviors that we trained families are being taken up effectively. So for example, maternal nutrition, there's a lot of cultural norms and practices that restrict maternal diet and even fluid intake. And we've struggled a lot on actually making a meaningful change in the communities that we work.
Shed, I'm just curious, how did you come to this work? You know, we heard from Reshma, we heard from the mayor, but how did you come to this work? How did you think, I need to kind of spend my life helping moms, babies, families be healthier?
Thank you. Of course, moms, babies, families are a big part, but we work with family caregivers across the spectrum of health conditions. I would say 2 things. One, as I was studying medicine, I just saw how much we relied on families for support, but how little we did as healthcare providers and health systems to actually support them. And it's not that we didn't want to, we just didn't have the time, incentives, tools, and structures to be able to do that. And secondly, just seeing this play out in my own family. I have a grandmother who had a very degenerative neurological condition, and my mother played caregiver, and I played caregiver, and she didn't speak English. She's an immigrant from Bangladesh. And so just navigating that whole process and just remembering and seeing what my mother did primarily to piece it all together was something that I saw as incredibly powerful. And if we were able to support and tap into that it would improve, obviously, the patient's health outcomes, but also caregivers like my mother, the burden on them and the anxiety, reduce that as well. And again, I saw it time and time again from hospitals in the US and now especially in being in India, Bangladesh, and Indonesia, where the doctor may spend less than 2 minutes with the patient just because of the intense demands on the system. And so interventions like these, I feel, are really required. So I guess, like many, it's something personal that brought me to this.
Reshma, I feel like you're nodding quite a lot.
No, I think that these are just the family and what happens in our communities, I think, are just so critical. And I think what leads us to this work. I think about, for me, I came to this because I started an organization called Girls Who Code. I had taught 600,000 girls to code. Half of them were under their poverty line. And then when the pandemic hit, you saw millions of women getting pushed out of the workforce, especially millions of Black and brown women who were marching their way out of poverty. And for so many of my students, they were going to go major in computer science. But because their mothers were essential workers and they were nurses and teachers and the people that we were relying on, quite frankly, for our livelihood, they had to, instead of going to college, stay home and take care of their siblings. And you just really saw how this generational cycle of poverty just continues over and over and over again because we haven't fixed the structure of care, whether you're in India, Bangladesh, or the United States. And I think it's just so powerful that we're having this conversation. And we're taking something that I think that so many of us talk about in the margins into the mainstream. I mean, how many women here went back to work before they were ready, after they had a baby? Raise your hand. And you never felt like you actually physically or mentally recovered, right? And this is something I think so many of us just talk to with one another, or our mothers, or our aunties, or our best friends, when this is a policy issue. And so I just think it's just so powerful that we're having this conversation here on this stage, to take it from something that we think that we have personally failed on, to take it to a place where we think society has failed us. We're not the problem. And I think it's just powerful that we're here and able to do that in this community.
Well, and I love that the mayor, spoke about like public floor strengthening, because I do think, truly, like we have to have specific conversations to then have sufficiently specific and supportive solutions. I mean, I remember, particularly after the birth of my daughter Charlotte, who's turning 9 next week. For those of you who are at CGI in 2014, you might remember I was hugely pregnant, and actually CGI was over my due date, and I just remember looking down at my belly and be like, come early or come late, but please don't come on time. And she complied and came quite late, as according to the schedule, but of course exactly when she was meant to come into the world, thankfully, healthfully. But I breastfed, and I spoke very openly about breastfeeding and about pumping, and the number of times that I would see people visibly recoil, like, you don't need to talk to me about that. And I'd be like, no, but I'm explaining like why I need the meeting to end on time. I guess maybe I just don't need to offer you an explanation, but I was trying to help you understand why I really can't, because everything was down to like a meticulous kind of schedule. And it was so illuminating to me, like the discomfort that people had with the basic like biology of caregiving. And so I wonder too, Madam Mayor, if we can turn back to you, because you spoke about kind of everything that you and the Conference of African American Mayors have put together to support mothers in our country, to tackle our birth equity crisis, our maternal mortality crisis. And I'm sorry for interrupting and making you explain WIC, but I worried not everyone may know what that would mean. But I wonder if you kind of had your druthers or a magic wand, what have we not talked about that you think we should be focused on to ensure that every mother has all the support that she needs, all the support that her child needs, and that the child has all the support that they need and that their families also deserve?
Well, it's what you just said. There's such a discomfort talking about the very critical issues. One of the questions was asked is why is women's health and maternal health in America, the worst of all the industrialized countries in the world? It's because women have not been a priority. We've spent more time focusing on how to prevent women from having control of their bodies than we have on supporting women to take care of and give birth to healthy children and to raise healthy children. We have to put the funding behind it. And I always believe that as soon as we have a revelation, we're saying, well, these are the things we have to do, and now I'm caught up, and now I understand, and I'm competent around policy. Policy means nothing if funding doesn't go to support it. And it means absolutely nothing. And so when you're talking about this crisis, and we're looking in urban communities right now, we are in the process of, for fiscal efficiency, shutting down hospitals in urban communities. I live in Mount Vernon. That's 20 minutes north of here on the Metro North. We are the blackest community north of the Mason-Dixon line in this country. But the focus for the past 4 years has been shutting down our hospital and saying, well, you can do regional health care, and not providing the support that you need for federally qualified health centers, not providing the child care support. So being a CEO of the YMCA, one of the most challenging things that I did, and my child care directors would come to me and they'd say, we have to kick parents out of childcare. The kids have to go home because these mothers are struggling and they can't get Title 20 subsidies, or, they're not poor enough for this, but they're not wealthy enough for this. So how are we dealing with those in the middle? And that is one of the biggest crises. We have programs for those who are impoverished, not enough. Those who have wealth oftentimes can take care of some of those basic needs themselves, but the majority of our country really lives in the middle, where we're struggling, and if you make a certain percentage of the average median income, it means you can take care of yourself. And so we're not funding those programs properly. We're creating great policies, but we're not implementing them, and that's why I appreciate CGI, because we're not just talking about the problems, and we're not just advocating for policies, but we're talking about really boots on the ground. Yep. How are we implementing the type of programmings? And so funding is critical. Funding for city health departments. And it's not just city health departments, because 80% of communities in this country have residents of 100,000 or less. So oftentimes you're dealing with a county health department. And if you're in a county where they don't recognize the issues of the more impoverished or challenged communities, then that conversation is beyond them. So we really just have to have standards, and we have to have a very clear roadmap, which we give to our federal, our state, our county, and our local legislators and executives to really follow, to ensure that we're dealing with the comprehensive needs of women's health. And then maternal health is just a part of that continuum. But if women's health is not focused on, then maternal health is an afterthought.
And I just want to make a plus, too, because I'm like, ooh, preach. You know what I mean? I think the other two things I would add to this is we have to stop making it seem like we're the problem, right? For so long, even when you talk about like Black maternal health, well, what did you eat? What'd you do, right? It was never about, well, what's wrong with the system? And I think for so long we've fallen for that, right? We've been trying to, quote, fix ourselves, get more confidence, ask for what you want, like eat better, whatever it is, rather than say, no, the structure's broken. And what I'm so excited about this fourth pillar we're adding at CGI, we have the opportunity as we're building this pillar from ground up to focus on the structures and to stop making women feel like they just need to be fixed. And I think that that's really critical. I think the second thing that we have to do is we have to start mobilizing ourselves for power for ourselves. I mean, if you think about women's movements and mothers' movements, we will go march for our children, for guns, for climate, for health, but we don't fight for ourselves. And we have the opportunity now to build a voting bloc, I think that is bipartisan, apartisan, whatever, on paid leave, on childcare, on maternal health, right? And show the power and the ability of our numbers to make policy change. Because when they see us, they're going to act. But they have to see us.
I want to, and I know we're running out of time, but just building on what the mayor and Reshma said, and really the importance of supporting women, including as caregivers. And you spoke about your grandmother and your mother as being kind of such inspirations for founding Noura and what you're doing now. And I so appreciated you talking about where you have challenges too, because I think we also have to be candid about that as well in these kind of collaborative, co-conspiratorial, movement building moments. But I wonder, just in our final kind of seconds, kind of what, a similar question as I asked the mayor, like in the communities where you work, in Bangladesh and Indonesia and India, what do you think are kind of at the intersection of bold and reasonable kind of for structural changes? And kind of what would you want this audience to know about kind of what you're working on at the policy level and advocacy level, as well as kind of with the families and babies you support?
Sure. I think what we're trying to do is not new. It's just trying to recognize something that's very old, but it's a part of all of humanity, which is that we care for the ones we love. And I think systems all over the world, and health systems is the one that I'm, I guess, focused on, can support that in a much better way. And I'll just give an example of how health systems push this concept away. So in many of the facilities that we work, fathers are not allowed inside of the ward. And so when a lot of the key kind of moments of sharing information about childcare, about health in general, they're just not present. And it's because of just a structural issue with letting fathers in and just the policies around that. And so I think there are some really basic ways in which we can in which we can have systems actually acknowledge the way that humans, that way we just support one another. And if we were able to allow systems to do that, I think we can go really far. This might be one of the most cost-effective ways to improve care, to improve well-being, just by acknowledging what is happening rather than pushing it away. So I would say that's, yeah.
Well, acknowledge what's happening, name it, call as many in as we can, and be ambitious, because the scale of the challenge and the opportunity certainly demand it. Thank you all so much, and thank you for joining us.
Please hold your seats while the speakers depart. Please welcome to the stage Audette Excel.
Thank you very much, everybody, and wasn't that just such a wonderfully inspiring session? I'm delighted to be here today, and I just want to ask you now, we've been hearing a lot about maternal newborn health, just to lift for a moment and transport yourself to another part of the world, a part that's very dear to me, to talk about mothers and babies in Africa and what it is we need to do for them. I will never forget the day that I first drove down the red road to Chiwoko Hospital in remote Uganda nearly 25 years ago, against the backdrop of incredible beauty and lushness in an area that was the absolute epicenter of a terrible, brutal civil war. There was this wonderful bush hospital. I remember the intensity and the commitment of the staff. I remember the determination of the community to rebuild their lives and to give their kids hope. And I remember watching mothers and nurses holding tiny, jaundiced babies with their hands in the sun for want of a simple heat lamp. They put them on windowsills to try to get them in cardboard boxes to try to get them light. And in the rainy season, because there was no sunshine, almost all of them died. 20 babies a week were dying of entirely preventable causes in the hospital compound because of the lack of simple equipment. The community was crying out for help for the babies. Every child lost of preventable cause is a catastrophe for the family, for the community, and for our world. Through the skill, determination, and amazing commitment of so many people, Uganda now has a centre of excellence in maternal newborn health. The impacts and survival rates achieved at that centre are close to the same impacts and survival rates that are achieved here in the United States, that are achieved in my home country, Australia, and in many other high-income countries. So hand in hand with our Ugandan partners, Adara has shown how to increase survival rates for the sickest and the smallest newborns. We've maintained that for more than 2 decades. Close to 90% of babies survive in Adara Chiwoko's newborn care unit. This is a model of care we call Adara Newborn. Adara Newborn works because we build an ecosystem wrapped around newborns and their mums to keep them alive. We have 5 arms that support mum and baby through pregnancy, through delivery, through neonate ICU, through postnatal care, and then what we call hospital to home, to follow them back into the community. We've already begun expanding in Uganda. We will be in 10 facilities within the next 10 years, and with a very strong focus on public hospitals. Our goal is to halve newborn deaths and stillbirths in the time and the communities and the facilities we're working in. And to do that, we will save at least 7,000 lives. Our work has been acknowledged as best practice by the Ugandan Ministry of Health. I'm hoping there might be some Ugandans here today. We are a Gates exemplar of global health, and we're very proud that we've just been awarded the Washington Global Health Alliance Impact Award. But our vision, Uganda I'm talking about, and Africa I truly love, but the vision is global. As we show what Adara Newborn can do and how you can save very small and very sick newborns, many other countries can adapt and can adopt this Adara Newborn model. And we will be there to support them with knowledge transfer as they do that. It's been the honour of my life to represent Adara and to have partnered with those communities, those health workers, those teams, the Ugandan Ministry of Health, to ensure the quality of care to small and sick newborns. And I'm enormously privileged to be here today to make a commitment of $10.6 million to significantly expand our work. We need $30 million to get this job done, and it matters. If you want to be a part of this story, I really want to talk to you, so please come and find me. Together, we can change our world. So please join us. Please, come join us. Thank you.
Please welcome to the stage Shadi Martini.
Good afternoon, everyone. It's actually martini, just like the drink. Thank you for sticking around. I mean, after the other guests, I really appreciate it. I'm originally from Syria, from a city called Aleppo. Actually, I got my citizenship just before the 2016 election, and even though I was from Michigan, but my vote wasn't enough to flip the state to Secretary Clinton, which I regret. So before the crisis began in Syria, I managed a hospital in Aleppo. And I witnessed firsthand how access to quality health care was improving in my country, Syria, for my neighbors and loved ones. For decades before the war, key health indicators were improving and steadily increasing in Syria. But we also knew that there was some inequity in this healthcare system, and especially in remote areas and in areas northeast of Syria. And northeast of Syria was underserved even before 2011 when the crisis started in Syria. On the onset of the crisis, however, not only I was forced to leave my home, my city, and flee for my life, but also significantly eroded the progress my country had made in meeting health needs. The current reality is very bleak. It's estimated that more than 50% of healthcare workers had fled the country, and only 65% of hospitals and 56% of public healthcare centers are fully functional. These setbacks have affected vulnerable communities the most, and including women and girls, especially those living in hard-to-reach areas. This is the reason my organization, Multi-Face Alliance, is announcing a commitment to action to ensure better access to quality reproductive health and nutrition services in rural areas of northeast Syria. In addition to establishing a healthcare center in northeast Syria that will specialize in women's healthcare, we are also aiming to leverage healthcare workers' team that will cast a wide net in surrounding communities to prevent, identify, and treat malnutrition in pregnant and lactating women, as well as malnourished children under 5 years old. Through this commitment, Multi-Face Alliance will support the long-term growth and opportunities of women and girls in already a fragile health system, investing in Syria's future. Thank you very much.
Thank you for joining. Please make your way to the main stage session in the Grand Ballroom.